I want you to picture this scene. The scalpel just glides precisely through the dermal layers, following those relaxed skin tension lines on the face.
Right, the natural creases.
Exactly. And the surgeon carefully elevates the flaps, establishing this meticulously clear operative field. So now the superficial parotid tissue is fully exposed.
It's all laid out perfectly.
Yeah, and this is a Saturday morning list. It's supposed to be this incredibly straightforward, supposedly simple procedure to just take out a 2 centimeter pleomorphic adenoma.
Just a routine lump removal, basically.
Right. And I mean, the preoperative ultrasound confirmed the mass was there. The physical exam in the clinic corroborated it. Everything points to this being a totally routine superficial parotidectomy.
It's the kind of case you almost autopilot through, right?
Exactly. But when the surgeon actually reaches in and palpates the exposed parenchyma, like pressing into the glandular tissue itself, there's absolutely nothing there. Yeah. The tissue is entirely uniform. It's soft, yielding. The source material described it as feeling like a fresh piece of bread you can just press your thumb into.
Completely unremarkable tissue, which is terrifying.
Right. Zero tumor. And that's exactly the moment the temperature in the operating room just seems to plummet.
Oh, absolutely. Because you're staring at this ostensibly healthy, pliable tissue, but your preoperative diagnostic data, I mean, it unequivocally mandated that a solid mass had to be in that exact spatial coordinate.
Yeah, the tactile feedback is just completely contradicting the diagnostic imaging. And, the mass hasn't simply vanished, it is physically in the patient somewhere.
It didn't just walk away.
No. So this forces the surgical team to dig deeper. They have to venture into the deep lobe of the parotid, which is this region that's just fraught with, honestly, some of the most unforgiving neurovascular anatomy in the human body.
It is a total minefield down there.
And what they find hiding beneath that healthy superficial tissue isn't a simple 2 centimeter adenoma. It's this massive 5 centimeter tumor that is directly compressing and literally burying the facial nerve.
Right, more than double the reported dimensions. I mean, navigating an extraction of that magnitude, especially when the topography is so severely distorted by this undiagnosed mass, it completely elevates a routine Saturday morning list into a high-stakes crisis.
A total nerve-sparing nightmare. So, welcome to the deep dive. Today, we are taking you directly into the realities of this specific case documented by the Surgical Thinking Academy.
Such a fascinating case study.
It really is. Our goal today is to unpack the extreme complexities of the human body, expose the inherent blind spots of the medical technology we all trust, and really show why the word supposedly is probably the most dangerous word in medicine.
Without a doubt.
So how does a modern, fully equipped hospital completely miss a 5 centimeter tumor before making the first cut? I mean, a mass that size in the face is not subtle.
No, it's highly conspicuous. But to understand the failure, we really have to look at the physical limitations of the diagnostic tools they relied on, starting with the ultrasound.
Right, because ultrasound is pretty much always the first thing they use, isn't it?
It is. It's universally deployed as the initial investigative tool for salivary gland stuff for, well, very pragmatic reasons. I mean, it's cheap, it operates in real time, there's absolutely zero ionizing radiation, and it's fantastic at telling the difference between a fluid-filled cyst and a solid mass.
And it's great for biopsies too, right?
Oh, perfectly.
Right.
It's the gold standard for guiding fine needle aspiration. You can literally watch the needle tip penetrate the tumor capsule in real time on the screen.
So it's giving you immediate spatial feedback, which sounds great for a superficial, uncomplicated mass.
Yeah. If it's superficial, that combination of ultrasound and a targeted biopsy is highly reliable. But the critical failure here wasn't like a broken machine. It was a fundamental limitation of physics, acoustic physics specifically.
Okay, break that down for us, because I think of ultrasound kind of like sonar on a submarine. It sends out a ping, and whatever it hits bounces back. Why couldn't this sonar see a massive 5 centimeter mass?
Well, the sonar analogy is actually perfect. High-frequency sound waves travel really efficiently through water and soft tissue. But when those sound waves hit something really dense, something with a vastly different acoustic impedance, like bone,
They just stop.
they reflect. The reflection coefficient approaches almost 100%. The sound waves literally cannot penetrate the bone. They bounce entirely back to the transducer.
Oh, wow. And in the parotid gland, we're right up against the jawbone.
Exactly. The ramus of the mandible. The deep lobe of the parotid gland wraps intricately behind that vertical segment of the jaw, so that bone acts as an impenetrable acoustic shield.
creating an acoustic shadow.
Precisely. The region behind the jaw is cast into this complete posterior acoustic shadow. The machine sends a pulse, the bone reflects it, and the screen just registers void behind it. The ultrasound is physically blind to anything hiding in that deep pocket.
Okay, that makes sense as to why it couldn't see the whole thing.
Huh.
But wait, there's a weird detail here. The ultrasound report didn't say we can't see anything. It specifically documented a 2-centimeter tumor. So did the machine just, hallucinate a smaller mass?
Not a hallucination, no. It was a misinterpretation of a tiny anatomical fragment. The massive 5-centimeter bulk of this thing was lodged safely in that acoustic shadow. But as it grew, a tiny peripheral segment, about 2 centimeters of it, poked out just past the edge of the jawbone into the visible field. The source text calls it visualizing the shoulder of the iceberg. The machine only caught that protruding tip and was totally oblivious to the massive substructure anchoring it deep down.
That is wild. And it really highlights how operator-dependent ultrasounds are, right? Like a slight change in angle might have revealed more of it.
Absolutely. The diagnostic yield is inextricably linked to the precise angle of the probe, the pressure applied by the sonographer, and their dynamic interpretation in that exact moment. A tiny shift might have revealed the deeper extension, or it might have just hidden it entirely.
Okay, so knowing ultrasound gets defeated by bone shadows, the next logical step would be a CT scan, right? I mean, we rely on CT scans to see everything. Why wouldn't a CT instantly spot a huge tumor in the cheek?
Well, CT scans are amazing for certain things. They excel when there are stark contrasts in tissue density, which we measure in Hounsfield units. So they are unparalleled for spotting bone erosion.
Like if a cancer was eating into the jaw.
Exactly. If a malignant tumor invades the mandible, the CT spots that destruction instantly. It's also highly sensitive for finding calcified stones, blocking salivary ducts, or fluid-filled abscesses.
But the tumor in our Saturday morning case is soft tissue.
Right, and it's surrounded by normal, soft glandular tissue and delicate nerves. The Hounsfield unit values for all these different soft tissues are incredibly narrow. They're nearly indistinguishable on a standard CT.
So they just blend together on the screen.
Yeah, the normal gland, the adenoma, the muscles, they all just blur into this homogeneous gray continuum. The source text accurately describes CT imaging for this specific internal parotid tissue as profoundly muddy.
Muddy? That's not what you want before you cut into someone's face.
Definitely not. The spatial resolution is high, but the contrast resolution for these specific soft tissues is fundamentally inadequate.
Which brings us to the king of soft tissue imaging, the MRI. If they had just used an MRI before that Saturday morning, this whole nightmare could have been avoided, right?
100%. The entire trajectory of the surgery would have changed. MRI is the undisputed apex modality here, and it's really based on 3 distinct capabilities. First is characterization.
Meaning it tells you what the lump actually is, not just that it's there.
Precisely. MRI uses the magnetic properties of hydrogen protons, so it provides a predictive pathological profile based on relaxation times. We can actually deduce the cellular makeup before we even do a biopsy.
Wow, so how does a pleomorphic adenoma, the tumor in our case, look on an MRI?
Well, a classic pleomorphic adenoma has a lot of myxoid, water-rich stroma. So on a T2-weighted MRI scan where fluid shows up bright, that adenoma is going to be hyperintense. It practically glows bright white against the darker background.
Oh, that's incredibly clear. And what if it was cancer?
High-grade malignancies, like a salivary duct carcinoma, are usually densely packed with cells and have very little water. So they appear markedly high point 10 stark on that same T2 sequence. Plus, they usually have these messy, infiltrating borders instead of a neat, contained shape.
So right off the bat, the MRI gives you a huge clue if you're dealing with a benign glowing mass or a dark, infiltrating cancer.
Right. The second huge advantage is depth mapping. And this is vital because the whole surgical approach is dictated by where the tumor is relative to the facial nerve.
Well, wait, can an MRI actually see the facial nerve? I mean, the fibers are tiny.
No, standard MRI sequences cannot reliably resolve the intraparotid facial nerve plexus. The fibers are simply too fine. So we navigate that limitation by using a highly reliable anatomical stand-in, the retromandibular vein.
Okay, so how does a vein help us find a nerve we can't see?
Well, the vein is robust, prominent, and really easy to see on an MRI. And anatomically, the facial nerve invariably courses superficial to the retromandibular vein. Always.
Ah, so the vein acts as, like, a geographical meridian.
Exactly. The radiologist locates the vein on the scan. If the bulk of the tumor is sitting lateral or superficial to that vein, the surgeon knows the tumor is above the nerve.
But if the tumor is medial deeper than the vein, then you know you're dealing with a deep lobe tumor and you have to do a massive nerve-sparing dissection.
Exactly. And the third major advantage of MRI is spotting insidious extensions. Salivary cancers love to spread along nerves, tracking backward toward the skull base. MRI can clearly show that pathological nerve enhancement or show if the tumor is pushing deep into the throat.
Okay, so I have to ask the obvious question here. If the MRI is the undisputed king, providing perfect characterization, mapping the depth with the vein, and catching nerve spread, why on earth do we not just use MRI for every single lump from day one?
It's a completely fair question, but it comes down to resource stratification and healthcare economics. MRI machines are expensive, the scans take 45 minutes, and they're huge access bottlenecks.
You can't just throw every single person with a tiny, benign-feeling 2-centimeter lump into an MRI tube.
Right, the medical system would collapse. So clinical algorithms rely on specific rules of crossover to graduate a patient from a cheap ultrasound to an expensive MRI.
And what are those triggers?
The text outlines them explicitly. First, if the initial ultrasound or clinical exam raises any suspicion of deep lobe involvement, you immediately escalate to MRI. Same goes for sheer size. Anything genuinely massive gets an MRI.
Makes sense. What about the physical exam in the clinic?
That's a critical one. If a patient has a parotid mass and you look inside their mouth and see a bulge in the lateral wall of the throat or the tonsils, that means the tumor is pushing deep into the parapharyngeal space. That mandates an MRI.
Wow, so you have a lump on the outside of your face, but it's actually pushing the inside of your throat inward. That is terrifying.
It is. Also, any clinical signs of malignancy are automatic MRI triggers. Rapid growth, pain, the mass feeling hard and fixed to the jaw, swollen lymph nodes in the neck, and most alarmingly, any facial weakness.
Because if the nerve is weak, the tumor isn't just pushing on it, it's probably invading it.
Exactly. Malignant perineural invasion. And lastly, if it's a returning tumor. Recurrent pleomorphic adenomas don't usually come back as one neat lump. They come back as dozens of tiny satellite nodules scattered all over the old surgical bed. You need the MRI to map every single one before you cut again.
So the takeaway is clear. Ultrasound tells you something is there, and MRI tells you what it is and exactly where it lives. If the Saturday surgical team had noticed something was off and ordered an MRI, they would have seen the giant deep lobe tumor.
They would have consented the patient for a vastly more complex, multi-hour procedure. They would have prepared for a retrograde facial nerve dissection. Instead, they were operating totally blind, basically based on a fundamental misunderstanding of the anatomy.
Which perfectly transitions us into this pervasive myth about the parotid gland itself. Because if the MRI maps the territory, we really need to understand what that territory looks like. And apparently, a lot of the standard anatomy textbooks actually lie to us.
Oh, they do. We constantly use this terminology, the superficial lobe and the deep lobe, and saying that implies that there's a structural bimodality there.
Like there are two distinct anatomical compartments, maybe split by a wall of fascia or something.
Right, but that conceptualization is completely fictitious. There are no true anatomical lobes in the human parotid gland. It's just one singular, solid mass of glandular tissue. The division between superficial and deep is entirely iatrogenic. It's a fake border created by surgeons just to make the operation safer to navigate.
So what actually forms that fake border?
It's a living wire, the facial nerve. The nerve plexus courses directly through the middle of the gland.
It's kind of like a geopolitical border drawn on a map where there's no actual physical river or mountain range, you know? The nerve is just this invisible border that dictates the entire surgery.
That's a brilliant way to put it. Everything sitting above or lateral to that facial nerve plane is called the superficial lobe, which is about 80% of the gland. The 20% sitting below the nerve is the deep lobe.
So when a surgeon does a superficial parodactectomy, they aren't unhooking a natural lobe. They are meticulously slicing away the top 80% of a solid gland right off the delicate nerves and just leaving the bottom 20% behind.
Exactly. And to understand how hard that is, you have to picture the geography of the parotid bed. It's an incredibly dense, inverted pyramid just jammed into the side of the face behind the jaw.
And the neighbors in that area are, frankly, terrifying.
Very unforgiving. In the front, you have the back edge of the jawbone and the thick masseter muscle. In the back, you have the mastoid bone behind the ear and the big sternocleidomastoid muscle in the neck. Above it, the ear canal.
And the floor of this inverted pyramid, the deepest part.
The source text rightly calls it the dangerous neighborhood. You have the styloid process, and right next to that is the carotid sheath. That holds the internal carotid artery, the internal jugular vein, and cranial nerves 9, 10, 11, and 12.
Okay, so if a tumor starts growing in that deep 20% of the gland, it's surrounded by bone and thick muscle on the outside, and the carotid artery on the inside.
Right. It faces immense mechanical resistance if it tries to grow outward. It can't easily push past the facial nerve or the jawbone, so it takes the path of least resistance. It grows inward, pushing deep toward the throat.
Which leads to this crazy mechanical phenomenon called the dumbbell tumor, right? Explain how that happens because it's fascinating.
It's all about the fascial hammock that cradles the gland. The superficial layer of fascia on the outside of the gland is tough. The deep layer is thinner, but as it goes deeper, it thickens into this rigid band called the stylomandibular ligament.
Okay, so a thick ligament spanning from the skull down to the angle of the jaw.
Right. It creates this narrow, rigid, bony fibrous tunnel. So as our deep lobe tumor grows inward, it has to force its way through that anatomical bottleneck.
Ouch.
Yeah. And as the tumor herniates through that tunnel, the rigid ligament pinches the middle of it. So the part of the tumor left in the cheek extends into a sphere, and the part that pushes through the tunnel into the throat expands into a second sphere.
Connected by a tiny pinched waist in the middle. Literally a dumbbell.
Exactly. And extracting a dumbbell-shaped mass through a rigid keyhole without popping the delicate tumor capsule is just a profound surgical challenge.
And before they can even try to extract it, the surgeon has to totally memorize the order of the dangerous structures traversing that gland. The source text was very explicit about memorizing this outside-in sequence.
It's mandatory. It dictates the entire sequence of danger. From the outside in, the first structure you hit is the facial nerve.
Immediately deep to that.
A retromandibular vein.
And the deepest structure in the gland.
The external carotid artery. Nerve, vein, artery. Invariable sequence.
So with that mental map completely established, let's go back to that Saturday morning. We are finally ready to make the first cut. And the gold standard incision here is called the modified Blair incision. Why do they describe it as a lazy S or a lazy Z? Why not just cut straight down?
Oh, a straight cut would be terrible, cosmetically and functionally. It comes down to the physiology of wound healing. If you make a straight cut perpendicular to the relaxed skin tension lines, the healing scar gets subjected to constant pulling.
Because your neck and face are constantly moving and stretching.
Right. And that constant mechanical stress triggers a hyperactive healing response. A straight line would contract into a thick, ugly, highly restrictive fibrous band across the neck.
So the lazy S solves that.
It does. It hides softly in the natural creases. It starts right in front of the ear, curves smoothly under the earlobe, goes up slightly over the hard mastoid bone behind the ear, and then sweeps gently down into a natural neck crease.
And there's a very specific measurement they use for that bottom sweep, right?
Yes. The incision has to remain exactly 2 finger breadths below the inferior border of the mandible.
Why 2 finger breadths?
It's a critical safety margin to protect the marginal mandibular branch of the facial nerves. That branch often dips down below the jawline before curving back up to control your lower lip. If you cut too close to the jaw, you'll slice right through it.
Wow, okay, so the incision is made. Now they have to peel back the face, essentially. The text breaks down the meticulous layering required here, starting with the skin flap. And the stakes just seem incredibly high on this first step.
They are. The skin flap includes the epidermis, dermis, and a very thin layer of subcutaneous fat. And the surgical plane here is notoriously unforgiving.
Because if you go too shallow, the skin dies.
Right. The blood supply to that skin relies on a delicate subdermal vascular plexus. If you dissect too shallow and leave all the fat behind, you sever those tiny blood vessels. The flap will suffer acute ischemia, and the skin edges will literally turn black and die.
But if you go too deep...
If you dive too deep and plunge into the parotid fascia, you risk blindly cutting the peripheral branches of the facial nerve before you've even properly identified them. You have to find the perfect middle ground.
Okay, so they carefully lift the skin flap. The next layer they hit is the SMAS flap, the superficial musculoponeurotic system. The text says they raise this as a totally separate, thin, fibrous sheet.
It's tedious, meticulous dissection to lift that sheet off the gland without shredding it.
I was wondering about that. Why do all that extra time-consuming work to lift a thin sheet of fascia when the whole point of the surgery is to take out the gland underneath it? Why not just cut right through it?
Because that SMAS flap is a brilliant reconstructive asset. You're saving it for the end of the surgery. It serves 2 huge purposes. First, when you take out a chunk of the parotid gland, you're leaving a massive crater in the side of the patient's face.
Oh, right, a cosmetic defect.
Exactly. So by saving that SMAS sheet, the surgeon can fold it and stitch it down into the hole at the end of the case, effectively reconstructing the cheek contour.
That makes sense. But there was a second reason, right? Something about preventing a bizarre complication later.
Oh, yes. It serves as a crucial biological barrier to stop a completely absurd miswiring of the brain that happens as the nerves try to heal. We will definitely get into the weeds on that later, but just remember, saving the SMAS flap at the beginning is what prevents the nightmare at the end.
Consider it bookmarked. So the third and final flap is the subplatysmal flap down in the neck.
Right. Up on the face, you dissect above the muscles, but down in the neck, the surgeon intentionally goes deep under the platysma muscle.
And this is to protect that marginal mandibular nerve we talked about earlier, right?
Exactly. That nerve branch hangs out deep to the platysma muscle. So by lifting the muscle up as part of the flap, the surgeon essentially wraps the delicate nerve safely inside the tissue, shielding it completely from their own scissors during the rest of the surgery.
Okay, so the flaps are open, pinned back, the gland is exposed, but before they can even touch the tumor, they have to find that invisible border we talked about, the facial nerve.
The living wire.
Right. And finding a nerve you can't see sounds terrifying. You can't just go poking around with a scalpel, right?
Absolutely not. You have to rely entirely on rigid bony signposts that reliably point to the exact hole in the skull, the stylomastoid foramen, where the main trunk of the nerve exits the brain.
But the text notes there's a lot of confusion here between three things. The tragus, the tragal cartilage, and the tragal pointer. Break those down for us.
Sure. So the tragus is just that little nub of skin and cartilage right in front of your ear opening. If you dissect under the skin there, you find the cartilage that shakes it. And the deep edge of that cartilage forms a sharp, wedge-like point. That's the tragal pointer.
And it literally acts like a directional arrow pointing into the surgical bed.
It does. It points right toward the nerve.
Yeah.
But here is the fatal trap. It points toward it, it doesn't touch it.
Oh, so you can't just cut at the tip of the arrow.
If you cut directly at the apex of the tragal pointer, you will sever the facial nerve. The actual nerve trunk sits a full centimeter deeper and slightly forward and lower than the pointer. Plus, cartilage is flexible. A big tumor can physically push the pointer out of alignment.
Right, so relying only on a bendy signpost is a recipe for disaster. We need something solid.
Which is why the most reliable landmark is a bony groove called the tympanomastoid suture. It's the crack where the ear canal bone meets the mastoid bone. It's solid rock. It does not move.
So how do you use it?
The surgeon feels for that bony fissure and traces it inward. The main trunk of the facial nerve will always be exactly 6 to 8 millimeters directly deep to the end of that suture line. Every single time.
Wow, that's incredibly precise. And they use a third landmark too, right? The digastric muscle?
Yeah, the posterior belly of the digastric muscle. If you find the top edge of that muscle and follow it back to where it attaches to the skull, the nerve trunk is right there, just in front of it.
I kind of think of this like triangulating a cell phone signal. You can't just use one tower. You need the tragal pointer for the general direction, the bony suture for the exact depth, and the muscle for the elevation. When all three intersect, boom, the nerve is in the crosshairs.
That's a perfect analogy.
Right.
And finding the main trunk first and then carefully following all its branches outward is called the antegrade approach. It's the standard, safest way to do the surgery.
But our Saturday morning case was not standard
No, it was not.
because that massive 5-centimeter tumor was sitting directly on top of the main nerve trunk.
Exactly. The tumor completely obliterated access to the bony suture, pushed the muscle out of the way, and physically buried the origin of the nerve. An antegrade dissection was anatomically impossible.
So what on earth does a surgeon do when the starting line is buried under a mountain of tumor?
They have to instantly invert their logic. They abandon the search for the main trunk and initiate a retrograde dissection.
Meaning they work backwards.
Exactly. They go far out to the edges of the face, far away from the tumor, to find a tiny peripheral branch of the nerve in completely normal tissue, like maybe a branch down by the jawline. Once they find that tiny filament, they painstakingly dissect it backward, millimeter by millimeter, tracing it upstream toward the tumor.
That sounds wildly tedious, like tracing a single frayed thread back into a knotted sweater without snapping it.
It's technically exhausting. And to survive that level of stress, surgeons rely heavily on a machine that basically sings to them, the intraoperative nerve monitor.
Ah, right. How does that work?
Before the surgery starts, they put tiny needle electrodes into the patient's facial muscles, the forehead, the lips, the chin. Those are hooked up to a monitor. During the surgery, the surgeon uses an electrical probe. If that probe even gets near a branch of the facial nerve, the nerve fires, the muscle twitches, and the monitor emits a loud, distinct beeping sound.
So it's basically a proximity alarm for the invisible wire.
Exactly. If you're cutting through dense scar tissue and the machine suddenly screams, you stop cutting immediately.
And the text mentioned the surgeon actually dropping the probe out of sheer tension during this case.
Oh yeah, the cognitive load of a retrograde dissection around a massive tumor is immense. Hearing that alarm go off unexpectedly will spike your heart rate.
But the expert in the text had two really vital warnings about relying on this singing machine. The first was about the anesthesia team.
Yes, this is critical. The whole monitor relies on the muscles being able to twitch. If the anesthetist uses a long-acting muscle relaxant, a paralytic drug, to keep the patient still, the nerve will still carry the signal, but the muscle is paralyzed. It can't twitch.
Oh my God.
Right, the machine goes completely deaf. You could slice right through the main trunk of the facial nerves and the monitor would stay completely silent. The communication with anesthesia to reverse those paralytics before the first cut is non-negotiable.
That is terrifying. And the second warning.
It's more philosophical. The monitor doesn't think for you. It's an alarm, not a GPS. It can't compensate for a surgeon who doesn't know their anatomy. It only confirms what you should already logically suspect.
Right. Okay, so after an agonizing retrograde dissection, the surgeon finally uncovers the whole facial nerve. It's mapped out. But remember the horrifying surprise of this Saturday morning? The tumor isn't sitting on top of the nerve, it's buried beneath it.
This is the deep lobe dilemma.
The source text used this incredible analogy for the physical extraction. It's like having a delicate, stretched-out net and trying to pull a giant melon out from underneath it without snapping a single string of the net.
It's a perfect visual. The surgeon has to dissect the main nerve and all 5 of its tiny branches completely free from the surrounding tissue. Then they literally lift that web of nerve up into the air, hold it out of the way with loops, and try to drag a 5-centimeter mass through the gaps between the nerves.
The stakes of that struggle just seem astronomical. What happens to the nerve when it's stretched like that?
You get what's called a traction injury. A nerve doesn't have to be cut to be destroyed. If you stretch a nerve over the dome of a huge tumor, you compress all the microscopic blood vessels inside the nerve itself.
So the nerve essentially suffocates.
Exactly. It suffers acute ischemia. The physical casing of the nerve might look perfectly whole, but the wiring inside stops conducting electricity entirely. This is called neuropraxia, and it causes temporary or sometimes permanent facial paralysis just from stretching it too hard.
Not to mention the bleeding risk, since the jugular vein and carotid artery are right next door.
Oh, massive bleeding risk.
Yeah.
But honestly, the tumor itself poses one of the biggest risks.
Right, because of the capsule.
Pleomorphic adenomas have a very fragile, inconsistent outer capsule. And inside, they're filled with this jelly-like mucinous stroma, and they have these microscopic little finger pseudopods that poke out through the weak spots of the capsule into the normal tissue.
So what happens if the surgeon squeezes the tumor too hard with forceps while trying to drag it past the nerves?
It pops, the capsule ruptures, and that jelly-like stroma spills everywhere.
And that's bad because it's full of tumor cells.
It's catastrophic. If that spills, it seeds the entire surgical bed with microscopic tumor cells. 10 years later, that patient won't just have one new tumor. They will have dozens of tiny, rock-hard tumor nodules scattered all throughout the scar tissue of their cheek and neck.
Oh, wow. And having to operate again through thick scar tissue with the nerve already compromised.
It almost guarantees permanent facial paralysis on the second try. That's why the absolute mantra of this surgery is gentle, whole capsule intact.
Okay, so even if the surgeon is a literal magician and delivers the tumor perfectly intact and doesn't snap the main facial nerve, you can't do an extraction of this magnitude without disturbing the neighborhood. There has to be collateral damage.
Always. There are sacrifices and consequences that are essentially guaranteed.
Let's start with the sacrifices. The great auricular nerve.
Right. This is a sensory nerve that comes up from the neck to give feeling to your earlobe and the lower part of your ear. Unfortunately, it runs straight across the pathway the surgeon needs to take to get the parotid gland out.
So it just gets cut.
Usually, yes.
Yeah.
It's routinely sacrificed. The patient will wake up with a permanently numb earlobe.
Which doesn't sound terrible until you think about putting on earrings or shaving your face.
Exactly. Patients really notice it. But there is a silver lining. If the surgeon accidentally cuts a branch of the main facial nerve during the surgery, they can't just leave it broken. They need a patch cable.
Oh, so they use the earlobe nerve they just cut.
Precisely. The great auricular nerve is the perfect, ready-made autologous graft. They just harvest a piece of it and microsurgically sew it in to bridge the gap in the facial nerve.
That is amazing recycling. Okay, what about the motor consequences if the main facial branches get stretched too much? The text had a mnemonic to remember the branches. To Zanzibar by motor car.
Yep, it's classic. Temporal, zygomatic, buccal, marginal mandibular, and cervical.
So what happens if the temporal or zygomatic branches get damaged?
Those control the upper face, primarily the forehead and the eyelid. If those go down, the patient can't raise their eyebrow, but more critically, they lose the ability to close their eye completely.
Wait, like their eye just stays open all the time?
Yeah, it's called legophthalmos. And without blinking, the cornea dries out rapidly, which can lead to ulcers and permanent blindness. We often have to surgically implant a tiny gold weight inside the upper eyelid so gravity pulls the eye shut when they try to blink.
That is intense. And the buccal branch.
That controls the cheek and upper lip. Damage there means food falls out of their mouth while chewing, and they get that classic drooping smile on one side.
And the marginal mandibular.
That controls the lower lip. If that's weak, when they smile, the good side pulls down normally, but the paralyzed side stays flat. It creates a very noticeable asymmetrical grimace.
Okay, those are all mechanical paralytic complications, but there was another one mentioned that was highly specific to the deep lobe, and it wasn't about paralysis. It was first bite syndrome. What is that?
Oh, this is a fascinating one. It's a dysautonomia, a misfiring of the autonomic nervous system. When surgeons dig deep into the parapharyngeal space, they scrape right up against the external carotid artery. And riding on the outside of that artery are tiny sympathetic nerves.
The fight or flight nerves.
Right. In the parotid gland, those sympathetic nerves normally act like a brake pedal. They inhibit the cells that squeeze saliva out of the gland. But during the surgery, those delicate brake pedal nerves get stripped away or damaged.
So the gland loses its brakes.
Exactly. The squeezing cells become hyperreactive. So weeks later, the patient sits down for a meal. Their brain senses food, and the parasympathetic system, the rest and digest side, sends a massive signal saying, make saliva, squeeze.
And because there are no brakes.
The cells go into an absolute uncoordinated tetanic spasm. It's like a massive Charlie horse inside their jaw. The patient experiences this sharp, excruciating, cramping agony with the very first bite of food.
And then what? It just hurts forever.
No, that's the weird part. As they keep chewing, the system kind of overrides the spasm, and the pain rapidly fades away for the rest of the meal. But it completely resets before their next meal. Every single first bite is agony.
That sounds miserable.
It is, though it usually slowly recalibrates and resolves over several months.
Okay, we've covered numbness, facial drooping, and jaw spasms. But the final consequence we need to talk about is so bizarre, it genuinely sounds like science fiction. And it brings us all the way back to the SMAS flap we saved at the very beginning.
Yes, Frey syndrome. It is the ultimate finale of aberrant nerve regeneration.
Okay, to explain this glitch in the human body, we have to talk about the auriculotemporal nerve. What does this nerve do?
It's primarily a sensory nerve for the side of your head. But crucially, it acts as a highway for hitchhiking fibers. It carries the secretomotor fibers from the brain to the parotid gland.
Secretomotor meaning make a secretion.
Right. These are the specific parasympathetic wires that tell the parotid gland to make saliva when you smell or taste food.
Okay, but the surgeon just removed the parotid gland.
Exactly. So thousands of these microscopic make saliva wires are just snipped and left hanging in the empty surgical cavity. They've lost their target organ.
And the body hates a loose wire.
The body hates it. The peripheral nervous system immediately starts a reparative response. Those cut nerves sprout and grow outward, blindly searching for a new end organ to plug into.
And because the parotid gland is gone, what do they hit instead?
They grow right up into the skin flap that the surgeon stitched back down. And waiting inside that skin are the eccrine sweat glands.
Okay, but a sweat gland isn't a salivary gland. The signals shouldn't match up, right?
You would think so. Normally, the autonomic nervous system uses different chemicals. The saliva nerves use acetylcholine. Most of the sympathetic nerves use a different chemical. But in a bizarre twist of human biology, the sympathetic nerves that control sweat glands are the rare exception. They also use acetylcholine.
Oh, wow.
The chemical locks and keys are identical. So the regenerating make saliva nerve physically touches the make sweat gland, releases acetylcholine, and the sweat gland accepts the connection perfectly. The miswiring is completely.
Wait, so when the patient smells food,
Their brain screams, "Make saliva!" The signal races down the newly miswired nerves right into the skin of the cheek, and the sweat glands go into overdrive.
eating becomes sweating.
Gustatory sweating. Every time the patient takes a bite of food, the entire side of their face flushes red and pours sweat.
That is just profoundly absurd.
It really is. And to diagnose it, clinicians use a test that looks like a magic trick. The Miner's starch iodine test.
How does that work?
They literally paint the patient's cheek with liquid iodine and let it dry. Then they dust the whole area with a fine layer of white starch powder.
Okay.
Then they give the patient something super sour, like a lemon wedge, to trigger a massive saliva command from the brain. As the patient chews, the miswired nerves fire, the cheek skin sweats, and that moisture dissolves the starch.
And starch plus iodine plus water.
Creates an instant chemical reaction that turns a vivid, deep, blue-black color. The clinician literally watches a dark blue map of the miswired nerves blossom across the patient's face in real time as they eat.
That is incredible. So how do we stop this from happening? Because you mentioned the SMAS flap from Section 3 was the cure.
The cure is entirely structural. Before the surgeon closes the skin at the end of the operation, they take that thick, vascularized sheet of SMAS fascia that they preserved, and they pull it tight over the entire surgical crater, roofing over the cut nerve endings.
Building a literal physical wall.
Exactly. When the cut nerve starts sprouting and searching for a target, they hit that dense fascial wall. They can't punch through it to reach the sweat glands in the skin. The miswiring is physically blocked. The end of the surgery was planned at the very beginning.
But what if they still get it? Because the modern treatment is Botox, right?
Right. If the barrier fails, we inject Botox directly into the sweating skin. Botox acts as a neurotoxin that specifically blocks the release of acetylcholine.
Ah,
So the miswired nerve still fires, but the Botox stops the chemical messenger from crossing the gap. The sweat gland never gets the signal, and the sweating stops completely. It's a biochemical fix for a structural miswiring.
what an absolute journey. I mean, we started with a simple 2-centimeter lump. We went through the blind spots of ultrasounds bouncing off jaw bones, the muddy gray CT scans, and relying on veins to map nerves on an MRI.
We dismantled the whole fake lobe myth and drew the real borders with the facial nerve.
We tracked the geometry of the lazy S incision, triangulating the nerve with bony signposts, doing a retrograde dissection around a massive hidden tumor, dropping nerve monitors, saving the delicate tumor capsule.
Down to patching nerves, jaw spasms, and literally sweating when you're supposed to salivate.
The ultimate takeaway from the Saturday case text seems to be, the case that's supposed to be simple is the one that teaches you the most. Don't operate on the scan, operate on the anatomy in front of you.
Absolutely. The imaging is just a shadow. The biological reality dictates the outcome.
Before we sign off, I want you to consider something. Think about Frey syndrome. When those nerves were cut, the body didn't just give up. It aggressively tried to heal itself. It desperately sought out a new connection to keep the system running.
It's incredibly resilient.
Right. But sometimes that blind, relentless drive to heal hits a weird biochemical coincidence, like the matching chemicals in saliva and sweat, and it results in this totally absurd, misdirected function. It really makes you wonder, how many other weird quirks, chronic pains, or odd reactions we experience in our daily lives aren't actually broken parts of us?
That's a great point.
Like, what if they're just the body's clumsy, overly determined, miswired attempts at healing itself after some tiny trauma we forgot about?
It's a complete paradigm shift. Viewing pathology not as a failure, but as the body successfully executing the wrong schematic.
Exactly. Thank you so much for joining us on this deep dive into surgical anatomy and medical mysteries, and never settle for what something is supposed to be.
Stay intensely curious.
We will see you on the next deep dive.